Okay, right. Hi, everyone. So as Sarah and Laura have said, I'm going to just basically over the next, I don't know how long it will be actually, until I'm told to stop. I will talk to you about how I feel that we should be managing. I'm mainly going to focus on the Gartland 3 supracondylar fractures, which I'll show you what I mean by that in a minute. But basically, those are the horribly deformed elbows. So who am I? I'm a paediatric orthopaedic consultant. I work at St George's. I've been working there for the last 3 years. I previously worked at Trauma Centre in the Royal London. So I've seen my fair share of these fractures. So that's my professional experience. I've also got personal experience. I've got my 3 little delights here, and 2 of them have had the most awful elbow fractures. So I'm going to use them throughout the talk because it's a bit easier. I don't need permission to just give some examples because they have had all the complications really that are associated with these fractures. So we've got the main type of supracondylar is your hyperextension injury, and that's when a child falls from a height onto an outstretched hand, and that's when you get that's what we call the Gartland classification for these. And really the 1s and 2s, the ones you definitely don't, if you want to know who you call orthopedics about, the ones I would always put in a back slab. Some people do just put in a collar and cuff and send them on their way, but I just don't trust crazy kids. I would always put them in a back slab and send them to fracture clinic. And the type 2s, usually if you just flex them up a little bit, and they may need some Entonox for that, and put them in a back slab again, check the pulse is still there after you flex them up quite a bit. They can just go to fracture clinic as well. But it's the Gartland 3s. There is also the Gartland 4 classification, but you can't really tell they're Gartland 4s until you get to theatre and realise they're wobbling all over the place. But this is going to be the mainstay of my talk today. There is also a different type of supracondylar that flexes up, but those are very rare. So just these are the mainstay. All right. So lots of things can go wrong with these fractures, which is why there's a lot of anxiety attached with them, and we just want to make sure that we manage each potential complication at the right point. So they are associated with nerve injury and vascular injury because of the nature of all the important structures that cross the elbow joint and the nature of the displacement that happens at the time of injury. They can go on to a malunion. That's quite common. You can see this child here has got the typical gunstop deformity, and this doesn't remodel. So it doesn't usually have any functional deficit. It's more cosmetic. Very rarely they go on to non-union or delayed union. I have had one child with that. It's usually after we've done extensive surgical dissection to reduce it. They can be stiff, which tends to resolve, infection, compartment syndrome as well. So these are all the things that we worry about, and that's why it's really important to get it right. So I'm going to basically give you an approach to the emergency management of these children, how to do a good neurological and vascular assessment and what's important, and then maybe give you an idea of what should be happening to these children who have got a nerve injury or have got no pulse, like how urgent this actually is. And I'll just give a brief summary of what we do in theatre and how we follow them up and rehab, and a couple of cases which really haven't gone that well. This is my son. This was the classic presentation that I think every supracondylar happens. It's usually in the afternoon when kids are jumping around, either from a bunk bed or a climbing frame after school. This was 4 p.m. On a Friday evening in the summer, because these tend to happen in the summer more. And he has got a puncture wound. It's an open supracondylar, and he didn't have a pulse. So he was taken to A&E. He was actually trauma called to A&E. So what should we do? I think that every child should be kept nil by mouth immediately, just so that you know that if they can always have a rapid sequence induction if they need to, but just keep them nil by mouth. Call orthopaedics. I know that they don't come straight away. I know that they're in theatre, but let them know. I think it's really important for orthopaedics to see the child before you start putting them in a back slab, because then what happens is orthopaedics come down and then they cut the back slab open and they need to have a look at everything, and it's quite difficult to do a proper examination once the back slab's on. I would get IV access and IV access and give them some intravenous morphine or Oromorph or intranasal, just some proper decent analgesia. Sometimes some diazepam can help as well because they're quite anxious. Sometimes the kids come in the you probably, because you work in it and you know the proper word for it, but the splints, the pneumatic type splints. But if you need to put a back slab on, if they're going to take ages, then fine, but I would try to avoid it until they've seen. So you're going to take a proper history, the mechanism of injury. Do they need to be trauma called? My son was trauma called because of the nature of his injury, and whether it's an open or closed injury. So you need to manage them according to the base 4 guidelines if it's open. And it's quite unusual with supracondylars, but with kids, we always have to think about NAI. So examination, you're going to look for, with your secondary survey, if it's a trauma call, or you're going to look for associated injuries. So this is what we call a floating elbow, when you have a distal humeral fracture and a distal radius and ulnar fracture. And sometimes this can be quite hard to diagnose, and I have actually been in theatre before when I thought I was just doing a supracondylar fracture, and actually as I was manipulating it, the wrist felt a bit, there was a bit of crepitus at the wrist, and it was in fact a floating elbow. When the child's really upset, and you can miss these things, and I would in this situation fix the wrist first and then go on to fix the elbow. You're going to do your vascular examination, which I'll talk about in more detail now. You're looking at the soft tissue envelope. This ecchymosis in the antecubital fossa comes from the distal part of the proximal fragment buttonholing through brachialis, and when I see that, I know it's going to be a difficult reduction, and I really like to get on and do these as soon as I can because they just get more and more swollen. You want to check the compartments, make sure they're nice and soft, and you're going to do your neurological examination, which I'll come on to as well in a minute. And it's really important that they've got good analgesia on board to do that neurological exam as well. Sorry. So this is just another slide to show that the distal part of the humerus buttoning holing through the brachialis. So this is just to kind of emphasize what is going on around this fracture. So you've got your brachial artery bifurcating into the radial and ulnar arteries, and then on the lateral side here, so you've got your radial nerve, your median, and your ulnar nerve. And as soon as you have that fracture, it really tents these structures in whichever way the fracture has displaced. And actually, if you imagine the moment of impact as well, that it's probably even the fracture was actually probably even more distracted at the time of impact. So there's a huge traction injury on these vessels and nerves at the point of impact, and then it's protracted as the fracture is not reduced. So this is what tends to cause the nerve injuries and the absent radial pulse, and it's not necessarily a transection, it's more just a traction, and it is in the most cases temporary. So the neurological examination, I think that this is the nicest way to do the examination, and there's a few people have written it up, but it's basically the game of rock, paper, scissors and the OK sign. and I think that it's nice to do it, as I said before, the back slab goes on, but you need to have good analgesia on board. And I think that it's quite traumatic for children to have this repeatedly as well. So it's better to just have it once and documented, and it needs to be motor and sensory. So extending the fingers as paper is the radial nerve, and you need to not just look at, if possible, not just look at the fingers, but you need to actually look at the metacarpal phalangeal joints as well. And the median nerve is just bending the fingers, ulnar is the scissor motion, and anterior interosseous, which is a branch of the median, is the OK sign. And from experience, I have to tell you, it's extremely hard to do this preoperatively and get a good assessment. And it's particularly important if you have got impaired perfusion to that hand, because that may prompt early exploration, because it might be that there is actually something trapped within the fracture site, rather than it just being a traction injury. So let's go on. So just coming back to my son Raf, he came in and everyone documented that his, sorry, I didn't talk about the sensory aspect as well. If I just do the edge of the little finger for ulnar nerve, median nerve, I would do the index finger, and the radial nerve is just the anatomical snuff box. I'm sure you know that, but just to go over that. But it's important, and you must document motor and sensory. So as I said, Raf, everyone documented neurovascularly intact, and then he came out of theatre and he had a complete radial nerve palsy, which actually no one, I didn't pick up until we got home the next day. So it just shows that when the back slab is on, it's actually quite easy to cheat. And because it was an open injury, the surgeon felt that he had seen the nerve and didn't need to go back in. But either way, I think, you can get an ultrasound scan in this situation, and if it shows the nerve is in continuity, I think it's really reasonable to just watch and wait, particularly if the X-rays post-operatively show that the fracture is reduced. If the fracture is not reduced properly, then that's a little bit more worrying, and I'll show you some X-rays of that later, because you're just worried that there may be something within the fracture site. And so this happened in August, and this was 3 months later. We just noticed, oh gosh, you can hear him. I'm sorry, I didn't mean to I tried to mute that actually, hang on. This was just a video for the surgeon to show that this is when I noticed that it was starting to come back 3 months later. No, do it slowly so you can see. So just notice. We can do that. But you can see, so that took about 3 months to just start to get that flicker of, I think it's ECRU started first. It was ulnar deviating slightly, but it did come back. But it's quite an anxious time. So coming on to the vascular assessment, you want to know, is there a pulse present? So if there isn't a pulse, I think my real take-home message would be not to panic. What you want to know is that hand perfused? And the way to determine that is to compare it with the other side. You want to know I'll go over exactly what a perfusion assessment involves, but it's looking at this hand, and if there's no radial pulse, you compare, I think it's 5 different components, and do it with the other side. We at George's just recently did a systematic review of preoperative vascular assessments, and I think it's quite helpful. It's on the next slide. I think it's also, this needs to be done. This is a decision whether you're going to be taking this child to theatre, and whether you're going to be transferring the child out of your hospital, or whether it can be managed locally. Because I think, and I'll show you why, but I feel, and we at George's feel, that these children that have perfused limbs, who have got an absent pulse, should be managed at their local hospital, because it really delays and increases the complications if you transfer them out. So this is what I would like you to measure with your perfusion assessment. You're going to do capillary refill, and that should be less than 3 seconds, and you should compare it with the other side. You want to compare the temperature of both hands. You want to record what you get on your SATS probe, and you should have a Doppler in A&E and look at the radial and ulnar artery flow on both sides and compare it. And the colour is slightly, you know, we always talk about this pink pulseless hand, and I feel that that's a little bit, you know, that's just really talking about Caucasian skin, and I think that can be quite unreliable. So I think we need to move away from that terminology. So, sorry. So that's your perfusion assessment, and then your pain management. You've given them analgesia. You're going to put them in a back slab. This is my other son who had an elbow fracture. You can see how much more comfortable he was once the back slab is in situ. So whilst I say do this examination, it should be done quickly, and I don't want to delay them getting their back slab. You just need someone who can do a really thorough examination. And when you put the back slab on, you need to get access to make sure there is still access to the radial pulse, whether there was one there initially or not. And you need to ensure that once you've done that perfusion assessment, this needs to be repeated, you know, there's no set rule, but, you know, half an hour to an hour, depending on where we're going with the management and what the initial findings were. But any increase in that cap refill or abnormal Doppler flow would give you a warning sign that there is impaired perfusion, particularly if there's a difference between that hand and in the uninjured hand, and also their pain score, because if their pain score is going up, that is a sign of ischemia as well. I don't think any of these fractures should have an attempted reduction in A&E. I think that creates more swelling, and if there is that concern, they should just be going to theatre then. Trying to think if there was anything else. So I don't think once you've done the reduction and fixed it, it definitely needs to include the wrist because it stops rotation. But I think this is just a splint until you get the child to theatre. So you need some x-rays in or out of the back slab. If it's more comfortable for the child, it's really fine to just do them in the back slab. I don't think it really matters. You know what you need to do for this kid, really. So what are we going to do now? So this patient's come in. It's Friday evening. It's now about 7 o'clock. They're comfortable because you've given them analgesia. The cast is on. They're nil by mouth. When are you going to operate? So, you know, really, I said here it depends on the examination findings, but it also depends on the orthopaedic team, I have to say. But if we go by the evidence and the guidelines, you know, there's both 11 guidelines who give clear management guidelines on supracondylars. They should be carried out on the day of injury, if possible. But if there is no compromise to the vascularity, or perfusion, if there's no, if the radial pulse is present and it's not open, it should wait till the next morning rather than middle of the night operating. And I don't think that, as I said, and I'll show you why. So this is a slight, this is a pathway that I have just put together in conjunction with the plastic surgeons at St George's over the last couple of months because of a few cases that patients have been quite delayed because of transfer to George's with no pulse but a perfused hand that didn't really need to be, and another ischemic hand. So what we just generally say as a rule, and it will depend on the orthopaedic team, definitely, and the surgeon that is on, but I think if there is a pulse present and the hand is perfused, so all of the cap refills normal, the Doppler, the SATS probe, you can admit them and they can have daytime surgery. If there is no pulse but it's perfused, they can be admitted locally and have their surgery done at that unit. Now, if the pulse doesn't come back during surgery, that's okay, as long as there's no signs of ischemia. And I will talk about what we do with those cases in a minute. But if there is no pulse and there's evidence of impaired perfusion, they should go to a centre that has plastics and vascular support. And they should have urgent surgery there. So this is just an example of a case that happened. It was a few months ago, and they had their 4 p.m. fall. They went to their local unit, and this is not just what this happens regularly. And I think this is what we're just trying to move away from. They have their fall, then they go to A&E. They find that they have no pulse. They finally get their X-rays, then they're referred to ortho, and then the local team, 5 hours later, decide they don't want to treat the patient. And then they're transferred to their tertiary centre, and they're not seen by a paediatric orthopaedic team till the next morning. At no point has any perfusion assessment been repeated, as I said, every 30 minutes. So you've got no idea whether this hand, which was a perfused pulseless supracondylar, whether that has now become ischemic or not. And then, they didn't get into theatre at George's till 24 hours later, by which point the skin went from this to this, and looks like it was an evolving type compartment syndrome picture, because they didn't ever need plastics. When I say plastics, it depends on the hospital. At George's, plastics do the vascular repairs, but other hospitals do vascular. Use vascular, and this delayed the pulse returning, but it did it eventually. But it made the surgery so much more challenging. And if it had just been taken to theatre at the local hospital, the child would have had a better outcome. So this is the pathway that we use at George's for pulseless supracondylars, and that we're trying to put together for the region. So you have a senior assessment at the time of initial presentation. And then you've documented that there's no pulse, and then you do your perfusion assessment, which we talked about, and then you do your formal neurological assessment to see if there's any radial or median nerve palsy, and then they should have urgent fixation that evening. And really, we know that if there's any evidence of ischemia at the second step, that's when you would transfer them out to a unit that has plastics or vascular. And indications for exploring on the table potentially would be a cooler. This is after you've reduced the fracture and it's a good reduction, and you think it's very unlikely that there would be anything trapped in the fracture. If it's a good reduction and there's still no flow on your Doppler, then you would be concerned that there is something trapped there, and you would explore on the table, or you would have a discussion. If you're happy with the perfusion and the pulse still hasn't come back, just close up. We just put the back slab on and we will wait. We would then send the patient home, and we would see them about a week later, 5 days later, and reassess. Quite often to check that, to see if there's any evolving ischemia. So you would go back and compare the limbs, see if it's cooler. And we get an ultrasound now of the vessels to ensure that they're in continuity and not trapped in the fracture. So what we do in theatre, if you remember those slides with the distal fragment, the proximal fragment buttoning holding through the muscle, I love lots and lots of muscle relaxant, because it makes it easier to reduce, and you put I don't try and manipulate it at all until the patient is draped on the table. I would not use a tourniquet, and then you basically have to. I missed the talk before, but I'm sure that they talked about traction, and with reduction, it doesn't need to be really forceful. It's just slow and continuous. And I tend to look at the clock, and sometimes I wait 10 minutes before I try a reduction maneuver. Which is essentially placing your fingers on the tip of the olecranon and using it as a fulcrum to as you flex the arm up. And you have X-ray and theatre, and then you hold it with wires and you place it in a back slab. I really try not to open these because I think that opening them just makes it much more unstable and makes the whole operation much harder. It's much easier if you have the periosteum there, and which is sometimes completely stripped, but just a casement of soft tissue to help with the reduction. And then you put it in a back slab, which comes up into the first web space, not like this. And then there's different ways of doing it. There's different camps. Some people don't like these cross K wires because the medial wire goes in. If you just feel your elbow where the medial epicondyle is, the ulnar nerve is just behind there. So this is when it's really important to know your neurological examination beforehand, because quite often I know from chatting to the plastic surgeons, they get a lot of patients that have had a wire straight through their ulnar nerve, and you know that it's an iatrogenic injury because they didn't have a nerve injury pre-op. So that's why that is helpful. And sometimes you need 3 wires because it's very unstable. And then there are lateral wires, which obviously avoid the medial epicondyle and therefore the ulnar nerve. But these are I think, more technically challenging. And if they're not done correctly, you can lose your reduction. I tend to personally prefer cross wires because I know where the ulnar nerve is and I'm careful, but I think and I do open it slightly and just check. But yeah, these sometimes, we know that there is a higher incidence of nerve injury with cross wires. So in an ideal world, if we're talking about how this all should happen, so he had his surgery on the Friday evening. He and is going home less than 24 hours later. So after that, you would come back to fracture clinic in a week. We would take off the temporary back slab, do a wound check the wires, put a nice full cast on and send them for an X-ray and check all as well. And then 4 weeks post-operatively, they would come back to clinic and they have their cast taken off and the wires are removed in clinic. We tend to use Entonox for that, but we are actually trialing some of those virtual reality headsets that I just saw that you guys were talking about at the end of the last session. I think it will depend on the child whether it works for them, really. And then usually at 6 weeks is the cast off and repeat X-ray. I don't get physio. I find that with these elbows come out and they're really, really stiff. And if you start forcing elbow movement really early on, you start to get like a capsulitis and ossification of the capsule, and it can become very stiff. So it's better I just say, just get them in the bath, just get them to start using it, and it comes back. And you always need to keep repeating that neurovascular examination as well. And if they have had a nerve palsy, when the cast comes off at this point, I would at that point refer to plastics or the nerve unit, whoever manages your nerve injuries. But that is all if the fracture looks good on the X-ray. So this is a case that there's a couple of cases now. So this is a case that was a pulseless supracondylar. I didn't see him when he came in. He was fixed with lateral K wires, and you can see here that really these wires are not gripping that distal fragment. There's not very much purchase, and whilst it looks okay in that lateral view, you can see on this other view that it isn't reduced properly. And he came back to clinic. He had his pulse hadn't come back. We got plastics to come and see him, and they did a Doppler, and they thought that they had a good signal there and that it was the same as the other side. And the hand was warm and he was sent away. But we checked on him 2 weeks later, and he came back with a start of an ischemic type contracture. And at that point, when you compared it, it was much cooler than the other side. And we got an ultrasound of the vessel. And this was actually the case that has made us change our management and be more aggressive with these type of fractures. Because I think when plastics went in, they found that the brachial artery was caught up in that bit of the fracture that wasn't reduced properly, and they had to excise it and do a vein graft. So now we would take this child back to theatre much sooner, and I hope that this pathway will prevent this. He has actually, children have got amazing resilience, and he has recovered well, but yeah, that was and I think also if you look at those, you know, he really needed a medial wire to prevent that rotation. This is another girl who was managed local hospital. She wasn't brought back within a week. She was brought back 3 weeks later, and these were her x-rays when she was brought back 3 weeks later. The fracture is completely malreduced, and the problem this had been opened at the time through both a medial and lateral window, and had been stripped the periosteum. So you have a big concern here that the blood supply to the distal fragment is going to have been compromised. And there was already lots of, well, we took her to theatre to make a decision whether we were going to take this down or not, but it was moving as one, and there was lots of callus, and all her nerves were working well, and there was a concern that we would go in and cause a nerve injury. So we decided to leave it alone. And she has healed in a basically in an extended position, and I don't think that this is going to remodel, and she will likely need an osteotomy to correct that deformity. But in conclusion, so this is my last slide, I think. I just wanted to show you that if these fractures, in the worst case, this is a pulseless, open supracondylar with a radial nerve injury, but he was treated on the evening of the injury I think he was in theatre within a few hours, and you know, he's had a really good outcome. His nerve has fully recovered, and I suppose my take-home point is that if even the worst type of these injuries, if they're managed correctly, they'll have a good outcome, really.